So non-PDL1, non-TMB and non-MSI markers for immunotherapy. Definitely we are struggling with the first three only. So what is the next? So when immunotherapy has really markedly improved, the survival in NSCLC patient, and it is absolutely introduced a new era. But not all patients of the lung cancer, they benefit from checkpoint blockade. So it is crucial to identify the potential biomarkers which are suitable for screening population that may or may not benefit from the immunotherapy. So these are the various other biomarkers which are non-TMB, non-PDL1, tumor-infiltrating lymphocytes, the neutrophil lymphocyte ratio, DNA damage repair, KRAS mutation, TP53 mutation, interferon signature, WNT catenin pathway, microbiome and radiomics. So this diagram, so all those students, again, definitely you need to revisit Grandfather Robbins, that is one of the most important chapter, the 9th chapter, neoplasm. You should always, look at this chapter. And, that time I always used to wonder, all these figures, whatever these cells, how these really make a difference. And now we realize what was their actual application. So number one is a tumor infiltrating lymphocytes, and as all of us know that the function of PD1, PDL1 inhibitors also requires involvement of lymphocytes near the tumor, and abundance of TIL may be used as a biomarker. So in NSCLC, abundance of TIL in primary tumor tissue has been associated with more favorable prognosis, especially the CD8 positive T cells, which often indicates good response to immunotherapy and a favorable prognosis. So it was actually seen in all tumors, even like metastatic melanoma, that CD8 positive tumor cells, tumor infiltrating lymphocytes, if they are there, they predict a better response. So proliferation of CD8 positive T cells, it has been directly associated with the shrinkage of the tumors on imaging after the immune checkpoint inhibitors treatments. So in Keynote 001, the number of CD8 positive T lymphocytes in tumor parenchyma and margins of the baseline biopsy specimen of the patients with effective pembrolizumab treatment were found to be higher as compared to those with the disease progression. So recently there has been bisonital, there is a radiological signature also has been developed, which actually predicts the response, especially in the presence of CD8 positive T cells. So this imaging biomarker could estimate the CD8 positive T cell count and infer the clinical outcome as patients treated with the immunotherapy. So these are certain 4 types which were developed, and this was actually based on tumor microenvironment, PDL1 and TIL. They are developed into 4 states. This was in stage 3 NSCLC who are receiving concurrent chemoradiotherapy. So type 1 is tumor lymphocyte positive, PDL1 positive. Their PFS is 70.6 months and OS is 35.3 months. Type 2 is TIL negative, PDL1 negative, PFS 13.1 months and OS 36.9. And look at this third type, TIL positive and PDL1, PFS not reached, OS not reached. And fourth is TIL negative and PDL1 negative, positive. This has a least PFS of 8.6 months and OS of 13.9 months with p-value of 0.11. So this result demonstrates that PFS and OS are longer in patients with high numbers of CD8 positive TIL, and it suggests that abundance of TIL may be used as a biomarker for immunotherapy. Next is the neutrophil lymphocyte ratio. Now we know that lymphocyte abundance mediates cytotoxicity, which is essential for ICI. But on the contrary, when there is a neutrophil is high, so neutrophil lymphocyte ratio (NLR) basically can be calculated in the tumor as well as in the blood, peripheral blood. So it is how it is calculated: is WBC divided by WBC minus absolute neutrophil count. If normal population, it is 0.7 to 2. If anything above 2.2 is considered the inflammatory condition. So neutrophils, they play important role in tumor inflammation. So large number of neutrophils, they causes proliferation and metastasis. And on the other hand, being involved, platelets are also marker of inflammation. They help the cancer stem cells and induce angiogenesis and favors metastasis by evading immune detection. So this is what is the role of NLR. Basically, it has a local tumor effect as well as systemic effects. The systemic effects can be seen as a cachexia, weight loss, there's appetite loss, the reduced immunity, and the local tumor effects is basically through the cytokines, there's an increased metastasis and evasion. So the question of the prognostic value of NLR in the lung cancer soon arose by Bagaret. He showed that pre-treatment NLR of 5 was correlated with inferior overall survival with NSCLC patient treated with nivolumab. A low preoperative NLR was correlated with better survival in stage 1 resected NSCLC, and more precisely, a preoperative NLR of 2.5 in stage 1 NSCLC has shown to lead statistically significant shorter 5-year survival. So NLR is something which we can look at. For the patients with locally advanced NSCLC, stage 3 and 3B, a low pre-treatment NLR seems to correlate with the better survival. Some results were observed even in the stage 4 NSCLC. The prognostic impact of DNLR, derived NLR early variation under immune checkpoint inhibitor therapy for advanced NSCLC patients similarly has been described, concluding that if high DNLR even is developed, it becomes low during the therapy, that is something is a predictor marker for the therapy response. So there is another score which has been developed, prognostic index, based on DNLR and LDH level. It is a called lung immune prognostic index, LIPI. But the only problem with the LIPI, it is only developed for the immune checkpoint inhibitors. So based on EP, if you have poor LIPI, have a shorter DFS and OS, but it has also been noticed, it is only with the immune checkpoint inhibitors. It is accessible, reproductive, and less expensive than other biomarkers. So combining this biomarker can be one of the things which can predict the immune checkpoint inhibitors. DDR, definitely, again, we are always associated with DNA damage repair, DDR, MSI. Most of the times we try to consider this together. The mutation status of the DDR correlates with the level of tumor mutation burden. And again, that is something which predicts the immune checkpoint inhibitor responses. So damage response and repair gene alteration, they are associated with increased tumor infiltrating lymphocytes and higher genomic instability, as well as higher TMB in the cancer, which are the predictor for the ICI responses. So MSI genetically hypermutational state, that is a phenotypic result of MMR deficiency. But somehow, as Dr. Rajiv also has suggested, role of MMR and MSI high in lung cancer, it still remains unclear. So DDR pathway with harmful mutations may be potential predictor for immunotherapy success. KRAS mutation, again seen in 15 to 20% of the NSCLC patient, particularly in smokers and lung adenocarcinoma. So notably, especially in CheckMate 057, it confirmed that patient with KRAS mutation benefited more from nivolumab as compared to those with KRAS mutation. When BURST study reported the patient with advanced NSCLC with KRAS mutation receiving atezolizumab had better outcome as compared to those with the wild type KRAS. TP53 mutations, again mutation rate of TP53 is 39 to 46% in adeno-CA. TP53 or KRAS, it increases the expression of PDL1 and infiltration of CD8 positive T cells. Now there are other mutations also where POLD1, POL, BRCA1, 2, like 3. Now all these mutations we have actually seen in the different tumor sites, especially POL mutation when we even see in endometrial carcinoma where it predicts the immunotherapy responses. So this mutation, they lead to an increase in the load of non-synovial mutation and number of tumor infiltrating lymphocytes, with making patients more sensitive to immunotherapy. So especially TP53 and KMT2C mutation, common mutation, that can predict the tumor response on NSCLC patient to the ICF well. So in one study it was found that PFS was significantly better in patients which has a co-mutation of TP53 and KMT2C, as with the significantly higher initial CD8 positive T cells, initial B cells, and the T helper type 1 and T helper type 2 cells in the tumor microenvironment. Interferon, again, these are the marker of inflammation. Especially in POPLAR trial, the high interferon signature was associated with improved overall survival in NSCLC patients who were treated with the atezolizumab. So PDL1 expression is closely related with the genetic expression of interferon. WNT catenin pathway, again it is correlated with the higher TMB and low expression of PDL1. So there seems to be inverse correlation between the level of catenin and level of TIL and CD11C. So it is also one of the pathway which can be looked at when we are having immune checkpoint inhibitor resistance. The loss of P10 and activation of PIK3 it reduces the level of cytotoxic T cells, and which promotes the resistance to immune checkpoint inhibitors. The last word about the microbiome. Now this is something which is more interesting concept. It's a dynamic collection of the commensal organism colonizing sites of the human body, and that has been found to have impact. Now usually there is a commensal bacteria and there is a crosstalk between the immune system. How actually it controls the innate immunity system is really not clear, but there is something that we look at. The response of level of the immune checkpoint inhibitors seems to be closely correlated with the bacteria, and there are various there are mice models where there are human models, and certain studies also given. Especially this bifidobacterium, there are various species they have studied, but the results have conflicting and no further conclusion. Except this, the Akkermansia mucinifera. Now this has been positively correlated with the ICI. The best survival response is if this bacteria was in a moderate quantity. So the median survival is 27.2 months as compared to if it is in the high quantities, it's just 7.8 months. And if it is absent from the gut, it is just 15.5 months. So this bacteria again seems to be a good biomarker for candidate for immunotherapy. So more recently in the Japanese trial, a Clostridium butyrem also has been seen, and this has also shown, if it is present, it has improved efficacy of immune checkpoint inhibitors. The role of radiomics. So currently this is a new era, it is AI based algorithms which has automatically, the only problem is they are more personalized. To develop as per institutional rule, they are going to be difficult. What is the advantage? They are non-invasive. The visualization assessment of the whole tumor is also possible. If there is oligoprogression, again we can offer them SBRT or other therapies. So there are 15 published studies with a meta-analysis, and the pooled analysis of the diagnostic odds ratio of predicting immunotherapy NSCVLC was 14.99. But the only problem here is that currently the methodology is not standardized for how to use it, and it was more of like homemade base which has been published in this various trial. So conclusion, the immune checkpoint inhibitors targeting PDL1 are radically changed, but almost 20% of the patient will finally really benefit from this. Why? Because PDL1 expression only is a variable. It can vary in even tissue biopsy. It can be heterogeneous. Second is it can be changed during the treatment, and some patient, despite of the PDL1, may not respond to. So we have need for additional predictive and prognostic biomarker, association of different biomarkers like PDL1 with MSI or TMB we can look at. But even commonly used biomarkers such as PDL1, TMB, we don't have any unified detection standard, and different conclusions are based on the same biomarkers. So today's research is mainly biosignatures, which is genetic, transcriptomic, proteomic or radiomic profile of markers which can reflect the multitude of pathogenic mechanisms. So these are what is exactly stated as the PDL1. We have limited specificity but predictive. TMB is there, but no standardized measurement method. TIL prognostic, but again limited standardization. LIPI, which is lung immune prognostic index, it is limited to lung cancer only, not at other sites. NLR, again there is no standardization, influenced by multiple factors. We have MSI, intercellular signaling pathway. They are more complicated. We still need to understand. And what is the future is probably a gut microbiota and radiomics. Thank you very much.